This is She's on Call, a weekly show hosted by ENT specialist Dr. Sujana Chandrasekhar and General Surgeon Dr. Marina Kurian. They'll be joined by guest experts to discuss an array of newsworthy medical and health issues. You're invited to ask the doctors anything. The physicians and their guests' views are their own and do not represent any institution. Please contact your doctor for any personal questions. Please hit share and join us live on Facebook, Twitter, and YouTube at She's on Call, hashtag She's on Call. Please welcome our hosts.
Hello, I'm Dr. Sujana Chandrasekhar. I'm an ear, nose, and throat surgeon with practices in Midtown Manhattan, New York, and in Wayne, New Jersey.
I'm Marina Kurian. I'm a general surgeon, a minimally invasive surgeon in New York City. And we have a really great show for you guys today. We're going to be talking with experts on addiction medicine. And if you guys know people who'd be interested, you should. It's live on Facebook, as you guys know, and Twitter. So definitely share this and tag your friends who might be interested. And our guest,
So we have two experts on addiction medicine and equity. We have Dr. Marlene Martin of UCSF and the San Francisco General Hospital. She is the director of addiction care there, and Dr. Ximena Levander in the Division of Addiction Medicine at Oregon Health Sciences University School of Medicine in Portland, Oregon. As Marina said, please like and share. Let us know where you're watching from, and let your friends know who might be interested in this really topical and very important topic. But as we do every show, Marina and I are going to talk a bit about the news of the week, and some of it is COVID and some of it is not. So Marina?
Well, I don't know where to start. I just want to warn everybody, I am in the airport lounge. So when you see people walking by me, that's what's happening. But I was so committed. I thought this show was great, and I thought I can squeeze this in, and we're really excited about it. In terms of the news of the week, I mean, you guys have seen that the vaccines are 3 of them, right? And the FDA and the CDC just said that we're going to approve a booster shot for both the Pfizer, the Moderna, and the Johnson & Johnson. And good news, bad news is that there are just as many people, if not more people, going for the booster shot than are actually getting vaccinated. And that's unfortunate, right? That there's 65 million unvaccinated, Sujana. And then now when we look at who's getting the shots, there are more people going in for booster. And they just approved it this week. You and I got different vaccines. I already got boosted.
Right. So I got Moderna. So hopefully I'll be getting my booster next week or the week after. I think it's really sad. I think it's very sad that 65 million eligible Americans have not gotten a single vaccine, while the rest of us are going to get our boosters and be safer. Professor Peter Hotez, who has really been a leader as we are understanding COVID for the past almost 2 years, a year and a half, year and 3/4 now, he posted on Twitter that over 90,000 Americans have died just this summer from the Delta variant of COVID, and the vast, vast majority of those were not vaccinated. So we're going to be talking to our guests about deaths from opioids and deaths from alcohol, but this is death from ignorance or willful ignorance or aversion to science, and it doesn't make any sense. The good news is that the boosters are approved. If you had Moderna or Pfizer, you can just get one of either of those or the Johnson & Johnson, so you can mix and match. If you had the Johnson & Johnson, you can get a second Johnson & Johnson or a single Moderna or Pfizer as your booster, so you can mix and match those. Anyone who got a Johnson & Johnson vaccine over 2 months ago is eligible for a booster. At the moment, people who are eligible for Moderna and Pfizer boosters are over 65, have underlying health issues, or are frontline workers with a lot of exposure. The FDA looked at the data for children. So currently vaccines are approved 12 and older in the United States. FDA looked at children, and hopefully we'll get approval for a half-dose vaccine for kids 5 to 12 by Thanksgiving. You know, worldwide, we're seeing another huge problem, right? We've talked about inequities in vaccinations around the world. 115,000 healthcare workers have died as a result of COVID around the world. And so, you know, the United Nations and the World Health Organization are really talking about equity, about trying to help people and
Other people
companies.
get the vaccine,
Yeah,
right? That's the problem. People
yeah,
are
you
not
just,
getting equity in terms of who is has access to the vaccine. Here we have all this access, and yet nobody. There's 65 million that are unvaccinated. So that's
right.
terrible.
So get a
It would be.
vaccine.
I think probably the people who watch our show do get vaccines. I think that would be a great poll, right? But we don't have polling options. In other news, we have ear news. It's funny how that works. Do you guys
Yes.
know how you can go into the pharmacy and pick up readers, like any Duane Reade or CVS, or, you know, if you go to Costco, of course, you'd get like 20 readers. But now I saw this news earlier this week, and then who do you think put it into the script for this week? Dr. Sujana Chandrasekhar, ENT surgeon.
Of
Go ahead, Suju.
course.
Share the news.
So we're really excited. So the FDA is making some hearing aids available without a prescription. So these are the entry-level hearing aids. There are red flag warnings about when you should see a doctor before getting your hearing aid. But right now the problem is immense, right? So only 1 in 6 younger adults and 1 in 3 older adults who need hearing aids actually have them. And that's because the cost is really prohibitive. At the moment, Medicare does not cover hearing aids. So this is a wonderful way to treat your hearing loss if it's early and avoid the onset of depression, isolation, and dementia that we see with untreated hearing loss. So yay, like the ENT community, the audiology community is so excited about this. So thank you, FDA.
Yep. Well, we're going to get to our show a little early, I think, because it's such an important topic, and we really want to get a lot of answers from our fantastic guests. And again, we have Dr. Ximena Levander, who in the Division of Addiction Medicine at Oregon Health Sciences and University and the School of Medicine, and also Dr. Marlene Martin of UCSF. She's the director of addiction care there, and we're excited to talk to them, not just about addiction, but also they have a fair amount of interest in health equity, which is something we were just talking about in terms of the vaccine. But unfortunately, equity of care is something that is not universal, you know, and that is so important. We're so thrilled to have you both on the show to discuss all of the things. We only have 54 minutes or whatever it is. It's just not enough time.
Well, welcome. And, you know, it's interesting. We're so glad you guys could come on today because it is the last day of National Addiction Treatment Week. And I think, and it actually is the first day of Red Ribbon Week. So October has a lot of medical things that it commemorates, including breast cancer awareness, as you know. But this coming week, most high school students in the United States will learn a bit about drugs and alcohol every single day for Red Ribbon Week. So this is a really good time to have the two of you on to share your wisdom. So thank you. Addiction, as you know, affects the individual, but it affects families and communities. And maybe we'll start with a definition. So Marlene, can you tell us what is addiction?
Yes. So here we have the definition of addiction: a treatable chronic medical disease involving complex interactions among brain circuits, genetics, environment, and an individual's life experiences. I think that this is something that we just need to highlight more in terms of people understanding that it's not somebody's choice. It's not somebody choosing this moral judgment that sometimes goes with addiction, that it's somebody deciding for themselves that, and then society and healthcare, the healthcare workforce, really approaching it with bias and criminalization, which is a lot of what happens in this country. And if instead we view it as this treatable chronic disease that affects multiple aspects of one's life, right? I think that's what's that it might be hard for people to wrap their heads around, that it can have so many medical complications, and it also has all of these psychosocial complications.
And I
For
think
me,
yeah, Marlene, it's the way you're approaching it. I think is a thing that we in our pre-talk with you guys. It's so important that we've since 2011 it's been called National Substance Abuse Prevention Month, but that is looking at it as a negative, right? In terms of saying, using the word abuse. What should it be called? It's substance use disorder right now.
yes.
And the taking that stigma out is so important, and I appreciate that you bring that up, and you brought it up to us, because we are like substance abuse, but it's not, right?
Yeah, the words that we use to describe addiction really matter, because they impose judgment. And we also know from different studies that have been done that how we document in medical charts, for example, if we use person first language like substance use disorder, addiction, a person who uses drugs, instead of words that I no longer use, for example, alcoholic, or if we refer to people as injection drug users, those terms, when we see them documented in chart, they affect how other people on the healthcare team treat that patient, and they affect the care that patient receives, and they perpetuate stigma. And so it's very important to use some of our person first terms.
If we can bring up that slide of the tree again, so that in a bigger view, right? So that, Ximena, if you can just talk a little bit about this, because this is a beautiful slide, really. It just really defines how we should be approaching chronic disease in general, and also specifically for this for substance use disorders.
Yeah, exactly. What other condition do we sort of, not the general medical, we assume that the patient is not telling the truth. And that initial, coming into an encounter with that sort of energy, patients can feel that. And that's why there's so much distrust and delay in coming and seeking care, because patients have been treated really poorly by individuals in the healthcare system, but also by the healthcare system in general. And so that's why we do see people come in with really serious, life-threatening infections and injuries, because they often delay coming to seek care because of how poorly they've been treated in the past. So we as a society and as a system have a lot of work to do, and that comes often at the individual level. So treating people with kindness and compassion, and that leads to liberation as opposed to stigma.
Well, thank you. We have, as I said, people watching from all over. Dr. Joe Diamond is a cardiologist. He's watching from Long Island. Helm Apollo Ali is watching from Philadelphia, and he asks where he can get his booster shot. Any place that gives shots. Helm, just walk in and show them why you are meet one of those criterias, and you can get your booster shot. Tim Sohn is watching from Pennsylvania. Ali A.K. Khan is watching. Barbara Valle is watching from Port Chester. Miriam Berkeley is watching from Hell's Kitchen. Oh my heavens. Veena Mishra is watching, and Aryaga is watching from Long Island. We have a DMs open on Twitter and Instagram at She's on Call. If you have questions for our guests that you want to ask anonymously, I think we want to respect your privacy and answer any questions that you have. When we talk about addiction, we talk about alcohol and drugs, but we also know that addiction can be addicted to screens, addicted to gambling. Can you talk to us, Ximena, a little bit about the different types of addiction and what's the underlying scenario?
Sure. So behavioral addictions are sort of starting to be more looked at and investigated, but I sort of think about it as like, how are we coping with something? And when I ask a patient, like, why do you use alcohol? How does it help you? Why do you use opioids? Why do you use stimulants? They'll often have an underlying reason for why they're using it. And so I think that's how I start to sort of have some shared humanity and understanding and compassion for people who use substances that happen to not be legal, is to sort of recognize that I also use substances. I'm currently drinking a cup of coffee, and it just so happens that caffeine is a legal substance. And so I think just recognizing that, asking people like why they use a substance and how that might be like and when it starts to become like a maladaptive coping strategy or behavior is when it starts to become concerning for a use disorder.
You know, that tree diagram was from the Harm Reduction Coalition, and a shout out to them for making something like that, which is so, as Marina said, so beautiful, so evocative. Joe Diamond, who is a practicing cardiologist, said, yeah, it's really important, the language that we use even in the medical record, because people have access, and that pejorative language puts a barrier between patient and healthcare giver. And I think it's really important that we do watch that. We had a question, how often, Marlene, I think Helm Apollo Ali asked this, how often are you called upon to give testimony? You know, as Ximena said, yeah, every time I fill out one of those forms, they say, do you take anything regularly? Yeah, I drink my cup of tea every morning, right? So how often are you called upon if somebody's used a substance and then gets into some sort of trouble with the law?
So I work in the hospital taking care of patients who are often hospitalized for reasons that might be tied to their substance use, but they're not necessarily coming to the hospital to seek treatment. And it's the primary team. So for example, the patient may be on family medicine or surgery. And then the clinicians on those teams will call us to see the patient. We do know that people use substances across the United States. Different races and ethnicities use substances at similar rates across the United States. It means white individuals use similar to Latinx individuals, to Indigenous and Black individuals. But we know that Black and Latinx individuals are up to 10 times more likely to be criminalized for their substance, for reasons related to substance use. So many of the patients that I have taken care of where I work, who happen to be 50% Black and Latinx, have often been criminalized, have often been in jail for reasons related to substance use. So this is one of the inequities I like to point out in terms of, you know, how do we punish people, and what we could do instead in terms of offering treatment.
Well, that's one thing, right? That there's UN data that shows that only 1 in 7 people who could get treatment actually do get treatment. So there's a lot of inequity there, but there's got to be, is it access issues, or is it related to just an inability to get it? Because the rest of the world, like in the US, you know, you don't have global healthcare or universal healthcare, right? You have insurance, you can get seen. If you don't have insurance, at some places you can get seen. Versus, you know, in Europe where healthcare is universal. So, why are we seeing that disparity, Ximena? Would you have a idea?
I mean, I think there's lots of different reasons why a lot of people who meet criteria for a substance use disorder don't get access to treatment. I think one, it's underdiagnosis or under-recognizing that someone has a problem and that they need treatment. I think part of it is people not seeking out treatment. I think a lot of it is access, like where is the treatment located? Is it provided by a healthcare setting or clinician that the patient feels comfortable with? Do they feel like they can trust that person to open up and talk about a sensitive topic? Do people know that there's treatment available? There's a lot of, I tell patients, like, especially with alcohol use disorder, where only 1 in 10 people in the US who meet criteria for alcohol use disorder get treatment. A lot of people think treatment for alcohol use disorder is AA. And while AA works really well for a certain percentage of the population, it doesn't work well for a lot of other people. And I think a lot of people think that if they're going to get treatment for alcohol use disorder, that means that they have to go to AA. And there's a lot of other options. And so I think that's another reason too, is a sort of like misperception around what treatment entails.
So I really appreciate that. I do not like the number 10 so far, right? So Black and Latinx people are 10 times more likely to be criminalized for their use. 1 in 10 people who have alcohol use disorder actually get treatment. Like those are terrible statistics. However, I think you brought into mind another question. How do you know when you're addicted to something? How does the family or the community or the person know? Because, alcohol, for example, is part of life. You go to any function, a parent social, for elementary school, and there's alcohol, right? I remember one of my friends who's a recovering alcoholic. She wouldn't go up on the porch where the drinks were, even to get a glass of water, because she just didn't want to be that close. She stayed, in the person's backyard. So we have some indicators of addiction. And I wonder, Marlene, if you can go through this and try to help us know when we're okay and maybe we're not so okay.
Mm-hmm. Yes, I think for somebody, for example, who's in recovery from alcohol use disorder or another substance use disorder, it can be hard to be around the substances. It's one of the main reasons here in San Francisco, where I work, that some of my patients will say it's hard to quit if they're in the community that has a lot of substances around, where they're consistently being offered substances, for example. But in terms of the way to diagnose a substance use disorder, we use something called that DSM-5 criteria. It's 11 different points. And so if somebody is developing
Marlene,
something
I'm just going to interrupt you. DSM is Diagnostic and Statistical Manual of
Correct.
Diseases.
Thank you.
Okay, sorry about that.
No worries. So if somebody is having cravings, that's one of the criteria. If somebody is continuing to use despite harm, physical and psychological consequences related to substance use, being unable to control the amount, like being unable to cut back, for example. And then there's a couple of other criteria that are on there, including something called tolerance, where as people are using, they have to use more to get to that same effect. And then withdrawal, where the body physically feels sick when somebody's not using the substance. And we often see this in the hospital, especially with opioid use disorder and alcohol withdrawal, where people may be hospitalized for physical consequences of their substance use. And if you have 2 of these criteria, you have a mild use disorder, 4 is a moderate, and 6 or more is a severe substance use disorder. I kind of just remember, the more criteria you're meeting, the more harmful effects it's having, the more impacts the substance is having on your life.
Right. If it's affecting your activities of daily living, or it's affecting how you interact with your family or with your coworkers or something, that plays into it. When we talk about alcohol use, and we're not talking about drugs, right? There's criteria for what's considered moderate use and heavy drinking. These were put out by one of the there's some criteria, I don't know who it is. So I know that if you're a woman, it's different than if you're a man. If you could just, Ximena, if you want to just kind of go through that for our viewers, because especially with the pandemic, I feel like if you were a light drinker before, now you're a moderate drinker. And I've told my friends, because I've done shows on this before, they're like, Yeah, I mean, I just, and this is guys, I'm like, you're a heavy drinker according to this criteria, and they don't feel like that at all. They're like, what do you mean? I'm not. I'm like, well, okay, but this is the numbers. I mean, so if we just go through that a little bit for our viewers.
Yeah, so there actually was a really great study done by the Research Triangle Institute International, RTI, looking at drinking patterns and behaviors during the pandemic. And they have seen and shown like a dramatic increase in people drinking more alcohol, especially early on in the pandemic, but then also sustained over the last year. And talking about equity, seeing that more in women and women with children, and especially in Black and Latino women as well. So I think thinking about who is drinking more and potentially why, going back to sort of the coping strategies, I think is important. There's a lot of stress and unknowns during the pandemic, but also having to now maybe have to like not be able to work and have to be at home and provide childcare would be very stressful. And there's a lot of pressure in our society for women to drink. If you look at social media, if you look at like TikToks and videos, there's a lot of sort of like drinking as coping strategy as okay, especially for women. And so I think that that's something to be mindful and aware of. But to your question about sort of amount of alcohol, heavy drinking is different by age and by gender. So for men, it's more than 14 drinks per week. And for women and people over the age of 65, it's 7 drinks per week. So that's another thing to keep in mind that I've noticed is that people who are over 65, people who've retired, it can be a little bit more challenging to go through those diagnostic criteria because people don't have the same work requirements. They're usually not driving anymore. Their responsibilities have changed. And so screening people who are over the age of 65 for alcohol disorder can be more challenging. And you have to be a little bit more nuanced in the questions.
So,
and I would use the term, one thing I wanted to add here is I would just use the term just like not heavy drinking necessarily, just unhealthy alcohol use. It means that you might have some consequences, unhealthy consequences from the alcohol use at that point. But in order to diagnose the alcohol use disorder, you go back to those criteria and then you can diagnose it that way, because some people may be having unhealthy alcohol use, but they're not yet having these severe consequences of substance use. And for them, it's just great to be able to talk about this, educate, and see where they are. Maybe they want to drink a little bit less. They may have no idea that the amount they're drinking could actually be harmful to their body, for example.
Yeah, thank you. Saida Garrett is watching from Glen Ridge, New Jersey. Sumana Rangachar says this is a really important topic. Bernard West is watching from Dubai in the United Arab Emirates. Let's talk a bit about alcohol use disorder. So I think as the person or their family becomes more aware, there is some really great graphics and information that you sent over, Marlene, for us, looking at alcohol use disorder. It affects 14.5 million people over the age of 12 in the US and 500,000 teenagers between the ages of 12 and 17. That's alcohol use disorder affecting 500,000 teenagers. More than 1 in 10 children in the United States live with a parent who has alcohol use disorder, and alcohol use accounts for 95,000 deaths per year here. So Marlene, how do we help? What do we do here?
What I like to do with my patients in the hospital is just sit and have a conversation. Going back to some of the points that Ximena brought up earlier, just ask patients, what they're hoping their goals are in terms of their alcohol use, how alcohol use is affecting their lives, how it's connected to why they're in the hospital, what they've tried before. Many times people have tried treatment already, different kinds of treatment, what has worked, what has not worked. Many people have had periods of sobriety, and really acknowledging that as a big win and acknowledging that this is a chronic disease and there may be dips and return to use, and periods where you've done this before. Congratulations, you can do this again, based on your current goals.
The fact about the 500,000 kids ages 12 to 17 is really scary. and shows you really how prevalent the disorder is. We are inundated by images of parties and, you know, fun ads for alcohol, right? And so the kids see that. And also if your kids see, you know, your parents' parties and everyone kind of starts out like a little bit, maybe not tightly wound or whatever, but then by the end of the day, everyone's having fun, you know, because they're drinking. So there's a lot of input that they're getting that, hey, alcohol isn't so bad. But also right now, we're seeing so much anxiety that in everyone, but also in the kids with the pandemic and the Zoom school and all of that. So how does this all impact kids? What are your societies, and what also is your experience in terms of maybe adolescence and how this is impacting them? Ximena.
Oh, yeah. So I mostly focus on taking care of adults, but I definitely hear adults tell me about their story about how they first started using substances. That's part of an addiction history, is asking people when they first started using substances. And certainly when I see people who started using substances when they were, you know, 8, 9, 12, 15, it's clear there was some early introduction to substances that maybe changed how their brain susceptibility was to other substances. I don't like the term gateway drug. I was a kid that grew up with DARE, which was, you know, the Just Say No campaign. And I think that both of those, like both using the term gateway drug and DARE, don't adequately prepare teens for the situations for when they're around substances. And it also tells, you know, kids, like, if you ever use a substance, all these terrible things are going to happen, but that isn't the case. People sometimes use one time or a couple times and it's fine. And then they're like, well, if my parents were lying to me about cannabis, maybe they don't know about other things too. And so I think it's important to be honest with kids and teenagers about how a substance affects their body, the potential consequences of using a substance. I think knowledge is really power. And if the knowledge you're providing children is to just say no, that's not really empowering them when they're in a social situation where they may encounter substances.
You know, so Matt Schifrin is writing, What About Weed? And one of the nurses I work with asked me last week to ask you guys, what about marijuana? It's become legal in many states in the United States. She lives in an apartment. The upstairs neighbor's always smoking. The downstairs neighbor's always smoking. She's fed up with it. You really can't walk through the streets of certain parts of Manhattan without getting quite a bit of secondhand. We think that people are self-medicating with that too, or sort of treating, you know, what underlying problem they're treating. And then we're seeing kids put it into jewel pods so that the parents don't even smell it. So there's so much that goes on with marijuana. And I think San Francisco's had a lot of experience with it for a long time. Marlene, maybe you can address that.
Yes, for kids, we know that early exposure to cannabis use can, if somebody has an underlying mental health diagnoses, that condition might come out sooner. It might present itself earlier. And we also know that when they've done studies that kids who are using cannabis before the brain is completely developed, so up to the mid-20s, will have a lower IQ. So I think it's really going back to that point that Ximena brought up, and making sure that we empower, that this knowledge is power, and that if we talked about what cannabis can do to the brain with teenagers, right, then they may make different choices.
I think that's a great point. I think anyone who's watching this, and I've told this to my kids, is that their brains aren't really fully developed, that they're still plastic up until, I think it's age 24 or 25. And so marijuana is so prevalent, the edibles are so prevalent, and it's been, they're fully aware that I don't endorse it for them at all, only because I want them to achieve their full potential and then let them do, what they're going to do. But I put that hard line out that they're age 25, and since I fund their lives, that's where we are right now. So I mean, they at least verbally acknowledged my input, and I think it's hard to police that because you just don't know what people are doing. And I think that plasticity of the brain is something that is, I feel like it's important. I don't know. I want everyone to achieve their full potential. What do you guys think of that research?
I think it's also important to tell people that just because you use substance as a teenager doesn't mean that you can't reach full potential. Because I think a lot of times I hear from people like, oh, well, I started using substances, so there's no hope for me, or like, I'm not going to achieve great things. And I think that also sort of attitude, I think, has been sort of said a lot in our society. And so I think it's important to be like, you use substances when you were a kid, we're going to get you into treatment, and we're going to treat your whatever the conditions were or things that were going on that maybe led to you using substances, and we're going to move from there and help you get to where you need to be.
So, there's a process, right? It's not, like the old wives' tale or the old high school scare tactic of, oh my God, if you smoke, a single joint, that's it, your life is over. That is not it, right? There's a process from going from your first use of something to eventually developing a substance use disorder. So Marlene, maybe you can talk us through these steps where we can intervene. Nobody wants to wait till the end, right? If we can intervene in the middle.
Yeah, it's, people are using substances for different reasons. And when you hear those reasons, right, when it's experiences of trauma and poverty, experiencing homelessness, to self-treat mental health conditions, many people dealing with depression and anxiety and other mental health diagnoses, criminalization, all of these things. When I hear these stories from my patients about sort of where like how they grew up, what their conditions were, it's so easy to understand why they have a substance use disorder, right? So just building that empathy and knowing that for some people, this is really, really hard to address, right? You can't just fix all of that overnight. You can't go back in time 20 years to do something about it. And so just moving from that, and then we can show this slide.
Sure.
So just, I think having these conversations early on with having the knowledge, and then if people are exposed once, and then, if they're having unhealthy substance use, being able to have a conversation about it so that people can potentially cut down. The data for this is a little bit mixed depending on what substance it is. And then once it becomes a substance use disorder, trying to really think about what sort of harm reduction techniques, what sort of, and you can practice harm reduction along the course of any of these steps. This ladder uses old terminology that we're not necessarily using anymore. Some of the dependence talk, but once somebody develops a substance use disorder, really giving individuals the different choices of how to treat this. There's medication for addiction treatment that for some substance use disorders really, really works well and saves lives. There's psychosocial, so behavioral treatment, group therapy like AA, for example, and there's other recovery groups, and there's therapy. And people can combine these, they can choose one, and they can also practice harm reduction and choose to make their the consequences of use less and improve their health that way.
Thank you so much for that, Marlene. I want to shift gears a little bit and talk about the opioid crisis. In New York State, we have to e-prescribe everything now. It's very monitored. We have all of these ERAS, which is early return. I'm forgetting what ERAS stands for right now, which I shouldn't. But anyway, basically all these different clinical pathways to try and get people out of the hospital in a healthy way and treat their pain appropriately. But opioids are still resulting in a significant amount of death. And Ximena, if you can just discuss that opioid crisis and what's going on in terms of if it's actually improving, because I feel like I just saw something that said it's not improving, and it's probably and likely pandemic related as well.
So there's a lot of factors that are leading to the increase in overdose deaths in the US. Part of it is the contaminated drug supplies and increased use of fentanyl and fentanyl-like substances, and then also increased use of other substances. So with overdose, not just opioids, but also seeing people using increased amounts of psychostimulants and benzodiazepines and combining different substances, which dramatically increases your risk of overdose. This is where it's really important to make sure that patients understand risk of overdose with opioids, especially if they're combining it with other things, if they're also on muscle relaxants, benzodiazepines, if they also drink alcohol. And so making sure to talk to patients about combining opioids with other medications, and making sure that patients have Narcan or a naloxone rescue kit, which is the opioid reversal agent, and that their family knows where it is, because you can't reverse an opioid overdose on yourself. So making sure that their family knows where the naloxone kit is.
Yeah, this is a harrowing statistic of 40,000 drug overdose deaths in the United States in 2010 and 93,000 in 2020. And that curve is not the kind of curve that we need to see. I think the use of naloxone is really very important. I think, we've all talked about, trying to help and understand why the use started and persists, and trying to get to what the patient wants for themselves, what they see for themselves as a success. We have talked about teens and screens in the past. We've had a couple of child psychiatrists on talking about that. Is there we're talking about alcohol and cigarettes and marijuana and opioids, but what is screen addiction? What is, doom scrolling? What happens when you while away, an hour or two or three, either playing internet games or on the internet, Marlene?
Wait, are you talking about kids, or are you talking about me now? I'm like, dude. That Instagram things, and like Twitter's harder. Like I don't go deep into Twitter. I think actually Suji does. She's on there, but like
TikTok, I know my kids talk about TikTok and something else, Snapchat. I don't know. So Marlene, what do you think?
There's different diagnostic criteria for different types of addictions, and I'm less familiar with the criteria for this. Ximena, are you familiar with it?
I'm not. I think it's a growing field. Like I said earlier, like behavioral addictions are a little bit more behind in terms of their study compared to tobacco use disorder and alcohol use disorder and opioid use. So I think we'll see more about diagnostic criteria for behavioral addictions.
The one thing that your Apple phone will show you is like, hey, look how much you're on your phone this week. I'm like, well, why do you have everything on my phone that I'm on it, right? That's how I deal. I do everything on my phone. I do work emails. I do I even review of papers, all the things that I'm supposed to be doing. And then Apple's like, oh, and you're on your phone a lot this week. I'm like, yeah, I was working, but it is good to track it, I think.
Yeah. I think it's just important to be mindful of how, going back to what I said earlier, why do you do a behavior? Being curious about yourself, why do I do the things that I do? Why do I choose to spend an hour on my phone? Why do I choose to check my email on my phone? Could I not check my email on my phone? Would that reduce the amount of time that I spend on my phone? Why does spending that much time on my phone bother me? And I think that's is it interfering with my life? Am I not doing the things that I want to do because of the amount of time I spend on my phone? And so I think just being curious around your behaviors and why you're choosing to do those behaviors, I think is a first step to try and sort of figure out, are the behaviors that you're doing problematic and causing issues?
We are live on Facebook, on Twitter, on YouTube, WBAI.org and WBAI something carries us on Mondays from 2 to 3 p.m. We have a podcast. So if you like this topic and know that we need to learn more about it, please like and share. Tag your friends who might be interested. As soon as the show goes off the air at noon today, it will be available on YouTube for you to watch. Marlene, can you talk to us a bit about the opioid deaths again? Like, let's just circle back about that.
Yes. We have a COVID crisis and we also have an addiction crisis in the US. In San Francisco, where I live, nearly three times more people died of drug overdoses than of COVID last year. And I look at this New York Times graphic and I see this December 93,000. And that was a 30% increase from 2019 alone. And what's even more disturbing is that as of March 2021 of this year, looking at the 12 months prior, we know that this number is likely going to be up another 30%. There's already more than 96,000 people who died that year. So this shows no signs of stopping. And then we've talked for a while about increasing mortality and complications of alcohol use disorder also, which is also on the rise. So that's 200,000 people who are dying every year in this country of treatable conditions, and especially opioids, where it's sometimes people are using things like cocaine or methamphetamine and they happen to have fentanyl and they have an unintentional overdose. Just so many young lives lost.
Yeah, it is really heartbreaking. I am so glad that you highlighted that, because these are, we're talking about preventable injury and death. And as we started, when treated with compassion. So I want to talk, we have a graphic about trying to avoid addiction triggers. So Ximena, maybe you can talk to us about, I talked about the person who won't go near alcohol because they're a recovering alcoholic. Can you talk to us about what are addiction triggers? How does one avoid them?
So this is why I think it's really important to also do behavioral therapy or counseling. While I really believe in medications for addiction treatment, I think counseling is a big part of it as well, to try and address the underlying behaviors. I think triggers are going to be unique for each person. I think this gets back to my earlier comment about sort of like being curious with yourself and identifying what happens in your own body and in your own mind in certain situations. I think also recognizing that you're not going to be able to avoid all triggers. And so figuring out what are you going to do when you come across a trigger that you weren't anticipating being there. I hear from patients all the time of, I just happened to bump into my friend, my former friend, and they, offered me something and it just felt natural. And I went back into a previous behavior pattern. And I think I'm sort of recognizing that we can't avoid every single situation that we can be in.
There's a lot of components of treatment, and it's not like, as you brought up before, it's not like it's just, you go to AA. There are other treatments that you can for, let's say, alcohol use disorder. But this graphic, while it's incredibly busy, is important to show our viewers how many different components are involved when you go into a treatment program. Can Marlene, do you want to discuss this slide a little bit, and then also Ximena?
Mm-hmm. Yes, for treatment for substance use disorder can involve multiple different things. I think of it in two avenues, and it's an and or between them. So for example, you have medication treatment for addiction, right? That's one option. And then you have what a lot of these things on this graphic show are behavioral addiction treatments. And we know from different studies that both of them work, and in combination, and at some of them in combination may also work. In terms of the pharmacotherapy, the medication treatment, a lot of the data shows that the medications work really well, and they work best for people with opioid use disorder. So opioids, we have fantastic medications. Some of the medications for alcohol use disorder also work. And we have a couple of different ones, 4 that are FDA approved. And then we have less great medications, really no FDA approved medication for stimulants. And so knowing that, and then knowing, okay, what are, in my community, what are all the behavioral resources? What are all the, what kinds of AA meetings are there, or NA meetings, or smart recovery groups, or what kinds of therapy are available to my patient in this clinic, or community-based organizations? And so having a champion, or going to a healthcare provider and being able to ask about what all the different options are, learning about them, right? There's also something called residential treatment, where people may go into a program for 30, 60, or 90 days. We may recommend this for somebody with a severe substance use disorder if that's really in line with the patient's goals and that's what they want. So being able to offer all of these to individuals and letting them make the choice, and they can choose medications and or the behavioral treatment.
I think you pointed out in the private chat, we fall into old words, right? So I said somebody is a recovering alcoholic, and alcoholic is really a pejorative term, right? It's like IV drug addict. It's a pejorative term. As you started in the beginning, you said it's not a choice somebody makes to do this. So I do apologize. And alcohol use disorder really shows the breadth of the problem as opposed to the words that I use. So I do apologize for that. I think I've learned a lot just talking to you, but also reading some of the articles you've both written on substance use disorder and people who use drugs. So PWUD, I didn't even know that was a term, so now I know. Marlene, we've talked about racism. We've talked about the differences when Black and Latino or Latinx people are found to have substances on them versus white people. We have a comment from Ximena Rangachar. Is this an area, or this is an area where lawyers and doctors can work together? So this is really where we go out of our silos of just medical care and we think about society writ large. So Marlene, maybe you can talk to us about how we address the racist nature or the racism inherent in this issue.
I love that one of the viewers pointed out that it's going interprofessional, right? Going across disciplines and using, everyone has different expertise, and bringing together that expertise to think about how we can address some of these issues. And so one of the things that I think is like being aware of where the gaps are, for example. And in order to be aware, we really need great data that measures differences that groups may experience because of, for example, where they live, the kind of access to care that they have. We, in addition to some of the gaps that I mentioned in terms of who gets criminalized, we also know that people, certain groups are less likely to be offered addiction treatment, and then they're more likely to have fatal and non-fatal overdoses. So not only is the stigma and access to care affecting who gets punished for substance use, but it's also affecting people's lives, right? Who lives and outcomes, like and who may die. And so the paper that you just showed is part of an organization that I am a part of, EMERSA, and we came up with a few different goals for the organization that is meant to dismantle racism. And some of those goals include, one is increasing the workforce diversity, because we know that when the healthcare workforce reflects the broad diversity in all senses of the word, right? It's not just talking about race and ethnicity, but diversity across many different fields, that people are more likely to connect with that individual And people have better outcomes. We have data showing that. So one of the things we're really invested in is diversifying the healthcare workforce. And that's, I know, not just an issue in California, but across the country where our healthcare workforce is not very diverse.
Thank you for that. And I think that is, absolutely a step forward to try and be reflective of what your community is when you're delivering care. Ximena, let's talk a little bit about your research too. We only have 5 minutes left, and we want to hear about that. I just saw, and apparently you did a lot of telehealth as well during this time, and if we could talk about that, your research and that effect.
Yeah, so prior to the pandemic, there were a lot of restrictions on telemedicine that everyone sort of faced with reimbursement, but in particular for opioid use disorder, you weren't allowed to prescribe controlled substances without first seeing someone in person, and that got waived. So now we were able to start prescribing buprenorphine using telemedicine, and we saw that it dramatically increased ability to reach a lot of patients that we weren't able to reach. Now, at the same time, it can also hinder the ability to reach some people who have what we call sort of like there's like a digital divide in the US, where people don't have access to technology, to internet, especially in rural areas in Oregon, which is a huge issue. And they also don't know how to use computers or smartphones. And so there's some people where having access to telemedicine improved access, and for others, it worsened access. And that's what we're interested in trying to study.
So I think we found that across medicine, right? We found that those who had more access, and those who did not did not. But I think you're right. Removing some shackles of in-person visits in order to get the treatment that you need is actually really important. My mom, writing under the pseudonym of my dad's name, Sujana Chandrasekhar, is asking, should naloxone be part of every household armamentarium, like you might have a fire extinguisher in your kitchen? Marlene?
I think that having as much naloxone available in as many places as possible, so that we can all be first responders, we need an all hands on deck approach. We do have an naloxone shortage in some parts of the country, I've recently seen. And so making sure it's accessible, especially where many of our overdoses are occurring. The other thing with naloxone that I like to point out is that even when you're going to prescribe opioids for somebody after a surgery or a short course in the hospital or in primary care, I always offer naloxone. And the reason I always offer to prescribe naloxone is that when people learn oh, this opioid could have negative effects that has respiratory consequences, or if my kid gets into this, they could have, it changes your pattern. Not your pattern, but it changes your mindset. Oh, this medication can have dire consequences. And so by co-prescribing naloxone, you do that education, and it's hopefully prevents potential harm down the line.
That's amazing. Helma Lee says, how does he get naloxone so that he can be an ally? Ximena?
So some states, you don't need a prescription. You can get it directly from the pharmacist. You just ask for it, but then it won't be covered by insurance. So if you do want it to be covered by insurance, you do have to ask for it. I will say that some people have had issues, going back to maybe some discrimination, but if you have naloxone on your medication list, it can cause issues with getting life insurance. So just trying to be an ally can cause consequences. So just something to be mindful of, which is important.
That is so true. I would add that sometimes community-based organizations who are working with people who use substances have access to naloxone, and you can go get a training there, and then do that training, and then get naloxone from them. And that's one way to be an ally and to get around having to have it prescribed or having the insurance issues.
You guys, we've had such a fantastic show. We are sadly out of time. And I want to thank you both for joining again, Marlene Martin and Ximena Levander. Thank you so much for joining us. This show is built by our viewers. We do have a production team behind it. And we want to thank our producers and everyone involved. And Sujana, any final thoughts here?
Yeah, next week's Halloween. So adults, get vaccinated and wear a mask as you're handing out candy to those kids who are not vaccinated, please. And in 2 weeks, please join us as we're back live on November 7th to discuss prostate cancer and male sexuality after that diagnosis with urologic surgeon Dr. Ashley Winter and radiation oncologist Dr. Sophia Kamran. So thank you guys so much for watching. Be safe.